السلام عليكم. معكم أستاذ مساعد دكتور بسام محمد حميد، اختصاص علم الأمراض أمراض الدم. وياكم الآن نحدد إن شاء الله المحاضرة الأولى. Our lecture entitled Normal Hemostasis and Platelet Disorders.
In a first step towards clot formation, platelets are recruited to the site of vessel injury by now exposed molecules of the vessel wall, such as collagen and von Willebrand factor. This factor mediates the linking of platelets to collagen via a specific receptor in the platelet membrane. The resulting change of shape of the platelet from its resting state into the dendritic form indicates activation. The activated platelet in turn releases prothrombotic molecules such as adenosine diphosphate, ADP. By binding to its receptors, ADP induces aggregation. And recruits further platelets to the site. Thromboxane is another important mediator of platelet activation and aggregation. Under its influence, the platelets cross-link with each other. These interlocking mechanisms cause platelet activation to snowball. The clot grows rapidly. Activated platelets also trigger the coagulation cascade and thus the formation of thrombin. Thrombin, in turn, stimulates platelet activation even further, a continuous feedback loop. Additionally, thrombin induces the formation of fibrin for the mesh stabilizing the clot. The self-reinforcing process of platelet activation, crucial in the formation of blood clots, is an obvious therapeutic target in conditions caused by inappropriately triggered blood coagulation.
This video demonstrates example of how these platelet and coagulation systems work together. Work together and in order to prevent blood loss from blood injury. So our story for today is how these elements, platelet, blood vessels, and coagulation interact together and prevent bleeding. And abnormality of these mechanisms lead to a bleeding tendency or thrombosis. So in this lecture, the intended outcomes for you as a student to achieve: first, enumerate screening tests for bleeding tendency. Second, mention main clinical manifestation of a bleeding tendency. Third, identify the major diagnostic criteria of idiopathic thrombocytopenic purpura. And last, mention and understand the major causes of thrombocytopenia, that's to say, low platelet count. Why we are studying this? We study bleeding tendency because it is a life-threatening condition that lead to major mortality and death among patients. Second, it is a common condition that may be faced by many specialty who may face it in medicine, in surgical branches, in obstetric and gynecology, and in pediatric. All major specialties and minor specialties may deal with the bleeding tendency, and you should have uh, a proper understanding uh, of the mechanism of bleeding tendency and what is the pathology behind a bleeding tendency. Bleeding tendency is like a story. When someone is being cut on the skin, we see by a knife in the kitchen, or injury, or road traffic, or missile, bleeding will occur. So what is really going on? Bleeding due to blood vessel injury lead to damage of endothelial cells that present in the capillaries and microcapillaries. These This endothelial injury exposes what is called subendothelial collagen. Behind the endothelial cells, there is a subendothelial collagen. Subendothelial collagen have the chance to attach to circulating platelet in the circulation. Platelet attachment to subendothelial collagen named platelet adhesions. So first, we have platelet adhesion from circulating a platelet to the subendothelial collagen. There is a certain protein that will facilitate and support this process. This is called Willebrand factor. So we have platelet adhesion to the subendothelial collagen with the aid of Willebrand factor. After a platelet, as we see in the video, being attached to the subendothelial collagen, it will be activated. This platelet activations lead to provision of phospholipid for coagulation cascade and secretion of thromboxane A2 and ATP. These are present in platelet granules. Platelets secreting thromboxane A2 and ATP will aid in platelet aggregation. What is the platelet aggregation? More platelet from the circulations comes and attach to the platelet adhesive to the blood strategy, forming what is called primary hemostatic plaque. So platelet functionally have three phases: platelet adhesions, then platelet activations, and later on platelet aggregations. Abnormality in any of these phases, it is called as functional platelet disorders. So for a primary hemostatic plaque, that is means the first plaque that prevent bleeding, prevent blood loss, it is called primary hemostatic plaque. It's composed mainly from platelet and RBC. And to have a proper primary hemostatic, we should have good vascular system. The first response to vascular injury is severe vasospasm. Severe vasospasm will cause turbulence in the blood flow and will have chance for a platelet to attach to the subendothelial collagen. Then we have platelet adhesions, platelet activations, and platelet aggregations. Platelet aggregation also secretes some materials like serotonin that augment vasoconstriction. Vasoconstriction will reduce the blood flow and aid in the formation of primary hemostatic plaque. The formation of primary hemostatic plaque is called primary hemostasis. Primary hemostasis then, which is it depends mainly on vascular systems, small blood vessels, and intact platelet. Primary hemostasis is dependent on platelet and blood vessels. Also, as we mentioned, platelet will provide phospholipid. Why? Because this primary hemostatic plaque is a fragile hash. Hash in Arabic we call hash. It's fragile, it's delicate. So, as we see, when someone is injured and we touch the injured side, rebleeding will occur. This is because the primary hemostatic plaque is, is a fragile. So we need a cement-like materials. We need glue-like materials to reinforce this primary hemostatic plaque and forming what is called stable hemostatic plaque. This is a process called secondary hemostasis. Secondary hemostasis depends mainly on the formation of fibrin. Fibrin comes from fibrinogen by the action of activation of the coagulation systems that 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 is the thrombin is the key factor in it. So, in response to blood vessels, we have vasal injury, platelets forming a primary hemostatic plaque, and activation of the coagulation system that lead to formation of secondary hemostatic plaque or what is called secondary hemostasis. Secondary hemostasis uh, is backed up by coagulation factors, while primary hemostasis uh, usually due to the function of platelet and blood vessels. So what is the blood clotting cascade? How is the activation of the coagulation system help us in this response to injury? We will take it from bottom to up. The end result of that we need to secure and to cement primary hemostasis is fibrin. Fibrin comes from a protein called fibrinogen. There is a thrombin that will act on fibrinogen to transform fibrinogen into a fibrin. Thrombin in turn comes from other precursors called prothrombin. Prothrombin changed to thrombin via factor 10. So factor 10, activated factor 10, as you see, Latin X means 10 and A for activation. Factor 10 active will act on prothrombin to form a thrombin. Factor 10 activations by factor 7 that is usually present in the circulation and tissue factor. Tissue factor usually envelop the endothelial cells. As we said earlier, when we have blood vessel injury, we have endothelial cells damage. So endothelial cells after damage will, will help to express tissue factor. Tissue factor binding to the free factor 7 act together to activate factor 10, which in turn act on prothrombin to change it to thrombin and the formation of fibrin. Thrombin, after formation, will act on factor 12, 11, and 10, so will augment factor 10 formation, and with this will lead more and more thrombin, which will generate more and more fibrin. That is to say, thrombin is the most important initiator factor in the cascade, in coagulation cascade, because after formation of thrombin, it will activate factor 5, factor 8, also activate, not also treated here, factor 11 and 9. So augmenting this loop causes positive feedback to the generation of thrombin. In addition, fibrin formed still a soft it will need to factor 13, which is activated also by thrombin. Factor 13 will cause cross-linkage of fibrin fiber strand, make it from soft clot to a hard clot. So this is a summary of activation of coagulation cascade. So how we patient with the bleeding tendency will present, how the patient will tell her or his story. Usual bleeding tendency usually present in two anatomical sites, either mucocutaneous bleeding or what is called deep bleeding. Mucocutaneous bleeding means the patient present with petechiae and purpura, which is skin hemorrhage, pinpoint skin hemorrhage called petechiae, small points on the skin, or purpura, slightly larger, mucosal bleeding, epistaxis, gingival bleeding, menstrual cycle bleeding, menorrhagia. So we have mucocutaneous bleeding. Mucocutaneous bleeding usually refer there is a defect in the primary hemostasis. So when we have mucocutaneous bleeding, the defect in the primary hemostasis, which means the defect either in the blood vessels or in the platelets. While deep bleeding, bleeding into muscles, bleeding into joints, GIT bleeding, central nervous system bleeding, post-operative after 24-hour bleeding, these are usually due to defect in secondary hemostasis. Defect in secondary hemostasis means there is a defect in the coagulation system. So as you see, clinical manifestations may point out to the underlying pathology. If you have mainly mucocutaneous bleeding, this means there is a defect in the primary hemostasis. While if you have deep bleeding, joint bleeding, muscle bleeding, large hematoma, this is mainly a defect in the coagulation system. So, how we screen this patient? Patient presented with a clinical presentation with a bleeding tendency. We have mainly three important tests: platelet count, which we see by CBC, automated platelet counter, CBC. We have usual normal platelet count from 150 up to 400. When there is a reduced platelet count, what is called thrombocytopenia, the platelet count will be below. Some will say that we may do bleeding time. This is not a common test anymore, but it's useful for academic explanation of bleeding tendency. Bleeding time, we prick the skin and we record the bleeding. Usually, bleeding time usually measures primary hemostasis. So when we have a prolonged bleeding time, this means there is a defect in the primary hemostasis, either blood vessels or platelet. Test for coagulation, we have two tests: partial thromboplastin time, PTT. Partial thromboplastin time usually measures coagulation defects in factor 9, 8, 11, and may be used for heparin therapy treatment. As you know, heparin is used for treatment of thrombosis. Also, we have another test called prothrombin time. Prothrombin time measures mainly abnormality in factor 7 or 10 and fibrinogen. Usually used to monitor the anticoagulant treatment, that is warfarin. So these are the coagulation cascades in colorful scheme. You see in the red area, these are factors that will affect activated partial thromboplastin time, APTT. So any abnormality in factor 12, 11, 9, and 8, 10, prothrombin and fibrinogen will affect APTT. While prothrombin time usually affected by factor 7, majorly and may be affected by 10 prothrombin and pap. Where we have 4 screening tests: bleeding time, platelet count, prothrombin time, and partial thromboplastin time (PTT). So bleeding time and the platelet count, usually we assess the primary hemostasis, while PT and PTT we measure uh, coagulation function. So if we have a patient with a bleeding tendency, according to pathology, either there is a vascular abnormalities, platelet abnormalities, or coagulation factors abnormalities. Let's talk few words about vascular abnormalities. Vascular abnormalities, usually they have a systemic disease like infection, meningococcal infection, infective endocarditis, severe infection that lead to vasculitis and bleeding tendency. Second, hereditary hemorrhagic telangiectasia. This is a hereditary disorders in which there is a dilatation of blood vessels. So after injury, there will be inefficient vasospasms. Cushing's syndrome. Cushing's syndrome, it's a syndrome because of excessive steroid in the body. Either patient iatrogenic taking extra steroid, or the patient have adrenal tumors that secrete corticosteroid. Corticosteroid will affect vasospasm, so the initial response to injury will be diminished. Pinock-Schönlein purpura, a sort of vascular disease, mainly occur in children, and also will affect vascular integrity. Scurvy, that is to say vitamin C deficiency, will affect collagen. Also, Ehlers-Danlos syndrome will affect collagen formation. And as you remember, we said there is subendothelial collagen have important role in the platelet adhesions. So when we have abnormal collagen, this will lead to abnormal platelet interactions and bleeding tendency. Amyloidosis. Amyloid is a sort of disease when there is a deposition of abnormal protein around the blood vessels. So when we have excessive protein depositions in the smooth muscles of the blood vessels, this will interfere with vasospasm activity of the blood vessels. So amyloidosis will prevent muscle spasm in a proper way, so we'll have bleeding tendency. These are the common causes for vascular abnormalities that lead to bleeding tendency. The second major cause of bleeding tendency that we'll deal about this lecture is platelet disorders. Bleeding tendencies because of platelet disorders can be uh, classified into two major uh, disease. Either there is a decrease in the production, that is to say, bone marrow not forming platelets, like aplastic anemia, in which there is a bone marrow failure, like leukemic infiltration for the bone marrow in acute leukemia, like vitamin B12 deficiency. All these will affect bone marrow formation of a platelet, and this will lead to decrease the platelet count. So we don't have enough platelet to adhere to the injured blood vessels. So we have what is called thrombocytopenia. Thrombocytopenia is defined as reduced platelet count below normal level, usually 150, some says below 100. Platelet thrombocytopenia may be caused, as we said, by reduced production or abnormal distribution. Sometimes increased function of the spleen that lead to pull up the platelet from the circulations to the spleen. Other cause of thrombocytopenia, we have increased platelet destruction. That is to say, the factor of a platelet in the bone marrow is working good, but there is extra damage to the platelet in the circulations. Increased destruction either due to immune mechanisms. Most common causes is idiopathic thrombocytopenic purpura, or due to secondary causes, maybe drugs, maybe HIV infections, and others. Thrombocytopenia, as we said, we have reduced the platelet number, and as we discuss, this reduction may be due to B12 deficiency, immunological causes, sequestration of the spleen, and dilutional when we have massive transfusion. When we transfuse a huge amount of pint of blood during blood transfusion, so blood will be diluted and number of platelets will be reduced. As we see here, normal spleen, this is a picture demonstrating the role of the spleen in platelet sequestration. Normal spleen usually had about 30% of the circulating platelet. When we have hypersplenism, when spleen increase in size and function, it will take up about 10 to 90% of the platelet. So it will cause what is called apparent thrombocytopenia. This is thrombocytopenia. When we measure platelet count, we have reduced platelet count, but in fact, platelet not reduced, it is redistributed by the spleen. And we may need to remove the spleen. We do splenectomy to uh, to increase platelet count further. Sometimes we have a normal platelet count, we have a normal blood vessels, still we have abnormal primary hemostasis. This is what is called functional platelet disorders. Functional platelet disorders, as you remember in the beginning of the lecture, we have said that during response to injury, platelet have three functions: adhesion, activation, and aggregations. So abnormality in these functions lead to what is called functional platelet disorders. As you see here, platelet usually adhere to subendothelial collagen by a receptor called glycoprotein 1b with the aid of von Brandt factor. If this receptor is defective by inheritance, a disease will called Bernard-Sollier syndrome. So in Bernard-Sollier syndrome, it is inherited disease causing bleeding tendency and functional platelet disorders due to abnormal glycoprotein 1b. You may scan this information for your grade. You may be not really to go deep through functional platelet disorder as they are really rare. Sometimes there is a deficiency in Vol-Brandt factor, and we will discuss this in more details in the next sessions. Uh, there is another protein called glycoprotein 2b3a that is responsible for a platelet aggregation, that is to say, platelet to platelet attachment. When we have a defect in this protein receptor, we will have functional platelet disorders, and disease will cause Glanzmann thromboplastin. So this slide summarize in short, inherited functional platelet disorders. You can scan it quickly. They are a sort of rare disease. Just be familiar with the names and the receptor affected. Now we will come to the major topics. The major cause of a thrombocytopenia and very common disease and life-threatening disease called autoimmune or idiopathic thrombocytopenic purpura. As you see, the name explains itself. Autoimmune means the disease is due to immune mechanism. Some say idiopathic, that is to say unknown causes. There is no clear cause or clear etiology for the disease. Thrombocytopenic means the patient will have reduced platelet count, that is to say, thrombocytopenia. Because of the low platelet count, patient will have bleeding tendency, so we'll have primary hemostatic defects, and will be skin purpura, that is red discoloration in the skin. ITP, autoimmune thrombocytopenic purpura, usually present in young and middle age, more common in female, and usually have isolated blood abnormality, that is to say, thrombocytopenia without anemia, or reduced platelet count, reduced white BC count, neutropenia. Sometimes ITP, idiopathic thrombocytopenic purpura, could be primary, which means there is no other abnormality in the body, or could be secondary to other disease, like other autoimmune disease, like example, systemic lupus erythematosus, HIV infections, viral hepatitis, rheumatoid arthritis, uh, that is associated with other autoimmune disease called secondary IT. Pathogenesis. Pathogenesis means how the disease is formed, how the disease will happen. As we said, it is an autoimmune disease. We have abnormal autoantibodies, usually IgG. These autoantibodies will bind the platelets and causing these platelets to be phagocytized by reticuloendothelial system phagocytes. Macrophage in the reticuloendothelial system, mainly in the spleen, will phagocytize these platelets, causing a thrombocytopenia. Usual Usual lifespan of a platelet in normal individual about 7 to 10 days, while in ITP it's only a few hours. So there is a marked reduction in a platelet count, and patient will have severe bleeding. As we said, this is a peripheral destruction of the platelet. So when we examine the bone marrow, we will see the cells that's forming the platelet, the megakaryocyte, is actively present and actively working, and platelet turnover, that is to say formation of platelet, is intact, because the disease mainly due to peripheral circulation destruction. As you see in this picture, this is a purpura, red pinpoint discoloration in the skin. Usually patient present with insidious onset, insidious which means gradual onset, petechial hemorrhage, and female may have menorrhagia, that is to say increased menstrual cycle bleeding. Patient may usually have epistaxis, that's to say bleeding from the nose, gum bleeding, mouth bleeding, and sometimes they have intracranial hemorrhage, يعني central nervous system hemorrhage, which is fortunately this is a very rare complications. How we diagnose ITP? As you remember, we have a screening test. What do you expect? When we do bleeding time will be prolonged because there is a defect in primary hemostasis and the bleeding time prolonged. Usually we don't use bleeding time when we do anymore. When we do a CBC platelet count, it will be reduced. Bleeding time prolonged, platelet count low, reduced, there is a thrombocytopenia. Prothrombin time, PT, is normal as there is no defect in the coagulation system. PTT also will be normal as there is no defect in the coagulation system. So we have a thrombocytopenia. We should do a bone marrow examination to figure out if there is underproduction of platelets or there is a peripheral destruction. Usually bone marrow in patient with ITP is active and normal. Platelet count usually reduced. Hemoglobin and white BC usually normal. Blood film, when you see When we do blood film for these patients, usually have low platelet and no other abnormality. Sometimes leukemic patient or myelodysplastic patient may present with that thrombocytopenia. Bone marrow show normal, megakaryocyte are normal. So we come to the end. What we need to focus in summary. I need you to know what are the screening tests for a bleeding tendency as we explained. What are the pattern of clinical presentation? We talked about two pattern of presentation. So what are they? Review it, please. What are the laboratory diagnosis of ITP? How we can diagnose ITP? We explained it earlier. Please review this. And that